Okay, now I'm pleased to introduce our second speaker, Dr. Lutfor Rahman Molla from Bangladesh, and is going to talk on risk prediction of fever in neutropenic children with acute lymphoblastic leukemia. Dr. Lutfor.
Good evening. Thank you, Congress Committee, for giving me the opportunity to present this seminar, present these topics in front of you. I am Dr. Lutfor Rahman Molla from Bangladesh. My topic is this prediction of fever in neutropenic children with acute lymphoblastic leukemia. Acute lymphoblastic leukemia, we know acute lymphoblastic leukemia remains the most common malignancy in children. It accounts for 1/4 of all cancer in children and approximately 75% of childhood leukemia. Remarkable advance had been made over the last 55 years in the treatment of acute lymphoblastic leukemia. Acute lymphoblastic leukemia has been cited as one of the true success stories in pediatric medicine, with the cure rate improving from virtually 0 to overall disease-free survival of approximately 80%. It is notable that the advance in the treatment outcome have not resulted solely from the development of new chemotherapeutic drugs, but also various other factors that contributing to this success, including understanding of the molecular biology, adhering to proper protocol, improvement in the behavioral pattern like feeding and other supportive management. Among the patient with febrile neutropenia, the signs symptoms of infection and sepsis may be subtle upon initial presentation. Therefore, standard practice is to give a broad spectrum antibiotics when the patient presented to us. The majority of the patients have an uncomplicated course with negative blood culture, hemodynamic stability with timely marrow recovery. But few of them, these febrile neutropenic patients have a complicated clinical course, and these groups are known as high risk. So if the risk factors of these patients can be established, it would be a great benefit of this leukemic patient as well as their families. So rationally of this study was patient undergoing cytotoxic chemotherapy of ALL are at high risk of drug-induced myelosuppression leading to neutropenia. The risk of infection and the subsequent infection-related morbidity are significant in our center, Bangabandhu Sheikh Mujib Medical University, Bangladesh. Their fever may be only presenting signs of infection, and it is considered to be infectious origin unless otherwise probed. The onset of fever in a neutropenic patient is an indication of parenteral antibiotics, we know. In our center, hospital hygiene is not at the appropriate level. Moreover, visitor restriction is a major barrier in the world. Bathroom facilities are very poor. Patients, their caregivers, and visitors are using the same toilet. In contrast to adult oncology, there are no established and validated models to predict the risk to develop febrile neutropenia in pediatric oncology patients. So, only an evidence-based and, whenever possible, risk-based use of these preventive measures should be implicated. So, objective of this study was to identify for the identification of risk factors of fever in neutropenic children with acute lymphoblastic leukemia. And there was some specific objectivity that is to identify the possible risk factors, to detect the time to develop neutropenia, to detect the time period between neutropenia and fever, and identification of organisms and their sensitivity patterns. It was a prospective observational study, and it was studied in 1st February 2013 to 31st January 2014. It was studied in Department of Pediatric Hematology and Oncology Department in Bangabandhu Sheikh Mujib Medical University, Bangladesh. And total 40 patients of acute lymphoblastic leukemia was studied in this. Their initial history of initial presentation, initial total count, previous neutropenia, history of recent chemotherapy with their intensity, history of any associated comorbidity like diarrhea, shock, DIC, severe bleeding manifestation, behavioral history regarding toilet and feeding practice, number of attendance of specific patient during their hospital admission, their food habits during hospital admission at home, and the full examination was recorded. Patient with suspected septicemia underwent a thorough septic workup, including complete blood count, blood culture, urine culture, chest X-ray, stool routine examination and culture, throat swab from the involved side if there are any present, their metabolic workup including SGPT, serum creatine, LDH, and electrolytes were done. Blood was taken from the peripheral brain. Complete blood count was analyzed in our Sysmex auto-arranger machine in the department. Blood, urine, and stool culture were done in the microbiology department of Bangabandhu Sheikh Mujib Medical University. X-ray was done in the radiology department on that university, and in case of emergency kit, bedside X-ray was done. Antibiotic therapy was started in all patients after sending the blood, stool, or urine sample culture. Antibiotic was changed on the basis of the sensitivity pattern. If there was no improvement after 5 days of antibiotic therapy and the patient remained neutropenic, then antifungal therapy was started. In case of extreme mucositis and with the evidence of viral infection, antiviral was given. Myelosuppressive intensity were calculated on the expected duration of neutropenia. Grade 1 was non-expected. In grade 2, they were less than 10 days, and in grade 3, more than 10 days. This is the results and observation. Interestingly, maximum patient was male. In this table, myelointensive intensity was more in between the 5 to 10 years of the patient. This is the association of feeding practice with the intensity of myelosuppression. Here, traditional food was given in mild in grade 2, 3%, and in mild in grade 3, it was 29%, 8.7%. Majority patient was on neutropenic and freshly cooked diet. This is the use of association of active flavin solution with the intensity of myelosuppression. Interestingly, major proportion of the patient did not use antibiotic active flavin solution according to advice. This is also association of povidone iodine mouthwash with the intensity of myelosuppression. Here also a major portion of the patient did not use active flavin povidone iodine according to our advice. This is the association of nystatin with the intensity of myelosuppression. Here is also major portion of the patient did not use nystatin according to this advice. This is the association of malnutrition with the intensity of myelosuppression. Here, Whiteford Z score was calculated, and maximum intensity was those patients who are malnourished. Time interval between the therapy and the development of neutropenia was around 4.97, and development of neutropenia and fever, it was around 2.5 days. Duration of hospital stay was average. Duration of hospital stay was 8.56 days, and number of attendance per patient was around 2. And out of our 40 patients, 10% revealed growth. Blood culture growth was in 4 cases, urine culture growth was 3 cases, and swab culture growth was in 3 cases. So in conclusion, regarding risk of prediction of febrile neutropenia, it was found that majority of the patients did not follow their advice properly in using nystatin drop, active flavin solution, and povidone iodine mouthwash, but feeding practice at home was satisfactory. Organism isolation was only in 25 cases, and the mean duration of hospital stay was higher, and number of attendants are higher in our hospital, and majority of the malnourished patients suffered from grade 3 myelosuppression. Thank you.
Thank you very much. Any questions, Dr. Molla? I was wondering what protocol do you use for
We
your
use UK ALL 2003.
UCAL protocol.
UK ALL 2003.
Okay. Any question?
Thank you.
Okay, thanks. We'll go to you. Thank you very much.